Well, good morning, everybody. We're very excited about this hearing that we have this morning. The Republican Policy Committee and the Republican Conference are doing this as a joint hearing, and Senator Alexander went to vote first, so he can come back and then I can go vote, and so we can keep everything moving along. Very excited about the three witnesses that we have today, and we'll be introducing them right after my opening statement. Healthcare affects all Americans. We know that. It is a situation whether if you don't have health insurance or access to good quality health care, some people think, well, is there a crisis in America today? And I would submit that if you're a parent and your child doesn't have access to quality health care because it's too expensive, it's a crisis to you. If you're an employer and healthcare costs are running out of control and you can't afford to give your employees raises, or if you frankly just can't afford to stay in business any longer because healthcare costs have gone up too high, then it's a crisis. So I think we have some serious problems in the healthcare industry in the United States, and what this hearing is going to focus on is one of the best ways that we can control cost and, in fact, make healthcare available to a lot more people if you bring the cost down, and doing that through encouraging healthy behaviors. All three of our witnesses today have incredible personal stories as well as what they've done on a professional level, and we're excited about having them here today. On a personal note for myself, because of some of the meetings that I've had with Steve Burd, the CEO of Safeway, and following also Governor Huckabee's extraordinary personal journey and what he did in Arkansas, my own office has embarked on a little wellness program. It's all voluntary. It's a little contest. We're doing a percentage loss of body fat over the next 3 months, so we're all excited. Everybody's eating healthier now, and we call it basically the Safeway plan for our office. So it's pretty exciting, and it's interesting just in the first week how we have a little candy dish, and how that candy dish normally gets emptied in a couple hours, and it's been there all week, and it's still almost nothing out of it. So people are thinking about choices that they're making, and the bottom line is that not only will making healthier choices save money in healthcare, but people across America will be healthier. They will live better quality lives, and that's a big reason that we're having this hearing and trying to focus so much on encouraging people to make healthier choices in their lives today. Our guests today include Governor Mike Huckabee, who was diagnosed with type 2 diabetes in 2003. He lost 110 pounds by changes in his lifestyle, and then he applied those lessons that he learned in his state, launching the Healthy Arkansas Initiative, which focused on helping people increase their physical activity, improve their nutrition, and very importantly, cut their use of tobacco. Dr. Andrew Baldwin, just on another personal note, the females in my office and around the rest of Capitol Hill, we're very excited to have you here, Dr. Baldwin. And he is a physician with the Navy's Bureau of Medicine and Surgery and works with the U.S. Surgeon General on his Healthy Youth for Healthy Future initiative, a national program to combat childhood overweight and obesity. He also lives by his own example since he has competed as an Ironman triathlete. And before the hearing, we have over at the Policy Committee, we have a picture of Lake Tahoe, and I was just talking about that I'm going to be riding it's called the most beautiful ride in America. It's a ride around Lake Tahoe, and I thought that was pretty good, riding 78 miles around. And he said, yeah, I swam across that lake, and he took the short way. It was only 12 miles. And we also have Steve Burd, the CEO of Safeway. He launched at his company a consumer-driven healthcare plan that I believe can act as a template for addressing our national health care crisis. Overall health care costs, I'll let him actually tell the stories on exactly how much money that they saved, but the bottom line, through rewarding people, putting financial incentives in, they were able to help or encourage people to make healthier choices, and they've been able to bring their health care costs down significantly. A lot of people are saying we need to spend more money, more of our national GDP on health care today. And I would submit that if we do the things right, we actually spend, almost 17% of our gross domestic product right now spent on health care. That's at least 3 or 4% more than any other country in the world. And I would submit that we spend plenty of money on health care. We're just not putting the incentives in the right places. And I think that's a big purpose of the hearing today, is to show that if you do things right, you can actually lower the cost of health care and use some of those savings to make sure that all Americans have access to affordable health care insurance through the private sector. So with that, Governor Huckabee, why don't you start us off with your statements? Just feel free, and we'll just go right down the Governor Huckabee, and then Dr. Baldwin, and then Mr. Burd.
Senator, thank you very much. It's an honor to be here this morning. I want to begin with a statement that perhaps will sound a little out of character for the point, but we really do not have a health care crisis in America. That's the often used word. What we have is a health crisis. The fact is about 80% of our health care expenditures are spent in this country on chronic disease that could be prevented or cured if we had different lifestyles. And the 3 lifestyles primarily driving chronic disease are overeating, underexercising, and smoking. What we truly need is a transformational approach that approaches the health issue as one to change from our current system, which is not a health care system, it's a disease care system. We need to begin looking at prevention as opposed to intervention, because the entire health care system today is built on the idea of waiting until people are catastrophically ill and then seeking to intervene with the most extraordinarily expensive modalities of medical care. It's the equivalent of continuing to treat snake bites instead of killing the snakes before they bite us. One of the concerns that I think have to be addressed is that if we're going to truly see a health care reform, we need to look at it as being approached from systemic changes as opposed to programmatic changes. And by that definition, the entire system is upside down, because it is based from the way we train doctors to the way that we reimburse the physicians and the providers. It's all based on the idea of waiting until there is a disease, waiting until there is a crisis, and then trying to figure out how to pay for the intervention. Prevention, in the long run, is less expensive, but more importantly, it could make a significant difference in what is now, as Senator Ensign has already pointed out, an extraordinary level of our GDP, some 17%. I would point out that when I speak of the 80% of that being driven by chronic disease, a more startling figure is that approximately 85% of a person's lifetime medical expenses are spent in their last 18 months of life. And so what we really have is a small group of people at the end of life requiring extraordinarily expensive medical care, primarily because they don't run to the finish line, they don't walk to the finish line, they are drugged to the finish line with extraordinarily expensive medical treatments because they're chronically ill, and therefore the costs are staggering. One of the things I would point out is that America's health is a whole lot. It's been described like an NFL football game on a Sunday afternoon. 22 people down on the field who are in desperate need of rest, and 70,000 people up in the stands who are in desperate need of exercise. And that's a pretty good picture of what's wrong with the country today, is that there are health habits that simply are leading us to this level of chronic disease. My personal experience was one of having to find some transforming behavior, but it resulted in policy changes in my state. We became the first state in the country to recognize that if we can get people off tobacco, whatever costs there may be involved in that are much less than the cost associated with tobacco-related illnesses. So we began to cover in our Medicaid program and for state employees tobacco cessation programs, whether it was the nicotine patch, 24-hour-a-day availability of telephonic counseling. We knew that that would make a difference, and it did. I was able to sign a piece of legislation in 2005, the Clean Indoor Air Act, that recognized that a workplace ought to be a safe place. And we didn't ban smoking in restaurants and bars because we were trying to tell the consumers what to do. We put a ban on smoking in all workplaces, not just restaurants and bars, but all workplaces, because it was really a matter of workplace safety. People are still free to smoke. They can smoke themselves to oblivion if they wish. They just can't blow their smoke on someone else. So if they wish to inhale and hold it, that's fine. But once they exhale it, they have to do it outside so that they don't impose it upon somebody else. So actually, it's only a partial smoking ban. You're free to blow in all you want. You just have to hold it for as long as that would possibly be. Not being facetious, but the truth is we started looking at things, for example, giving employees cash benefits for their healthier choices. Simple things, $500 per employee, $1,000 if they included their spouse for doing a health risk assessment. We were amazed at how many people would simply do the health risk assessment because it was money in their pockets. When we provided the smoking cessation tools, a lot more people were willing to participate. We also included weight loss programming in our state employee health plan, three-tiered. One was an internet-based interactive approach. The second one, for those who were more seriously obese, involved physician assistance. And the third one actually involved covering bariatric surgery. And I know that's somewhat controversial in many quarters, particularly for coverage, but the truth is people who are morbidly obese have extraordinarily expensive health care costs, and every effort to try to control those can make a huge difference. So I know my time is limited here, and I'll close, but I do want to say thanks for taking on this issue, and I would hope with all my heart that there would be a sincere effort as we look at the changes needed in the healthcare system of America, not to so much look at just how to access more people into a flawed system, but to change the system itself. Because if all we do is get more people into a sinking ship, we really aren't doing the country and the future of our children a great favor.
Thank you, Governor Huckabee. You have not lost any of your good humor or your plain speaking, and you've been a real pioneer in the area of prevention and wellness. I think more of the senators are on their way as the vote occurs. I would only say that the health care debate is something Republican senators are committed to. We want to make a change. We want to do it this year. We want to do it in a way that makes sense. We want people to be able to afford their insurance, have choices, not have to wait in line. And your example, as well as your leadership as governor and nationally, has been a real effective way to put the spotlight on prevention and wellness. That is one area about this health care debate that we may find consensus on between Democrats and Republicans. So our challenge in the next few weeks is to understand specifically what provisions should be in the law that would make it easier for employers and individuals to give incentives for wellness and prevention. Dr. Baldwin, thank you very much for coming. We look forward to hearing from you.
Sir. Good morning. Thank you, Senator Alexander and Senator Ensign, for the opportunity to be here with esteemed guests and Governor Huckabee and Mr. Burd to talk about this important issue of health care reform. There we go. I'm appearing today in a personal capacity as an athlete and a physician, and not as a representative of the United States Navy. As a primary care doctor, I have seen the numbers of Americans with preventable chronic disease. 133 million Americans, that's one of every 2 American adults has at least one preventable chronic disease. And these preventable chronic diseases dominate our healthcare costs, $2.2 trillion each year, 3/4 of the costs go to treating chronic disease. So as Governor Huckabee mentioned, I too believe that the real healthcare reform needs to be a switch towards prevention. We need to hit the reset button and stop rewarding sick care and start rewarding prevention and healthy behaviors. The costs of preventing these issues upstream before they occur are considerably less than dealing with them downstream. Toward that end, in your legislation, I urge you to include funding for preventive medicine residency programs and primary care. More focus needs to be placed on prevention in our medical school curriculums. Having gone through that and seeing how little there is in our medical school curriculums today, and Also, preventive medicine training programs need to be funded and recognized throughout our country. Today, I'd like to speak about a serious health issue that I've seen with my own eyes in traveling throughout America, and one that I care passionately about, and that is the epidemic of childhood obesity. Currently in the United States, 1/3 of Americans are obese. That's over 72 million people. So in my 3 decades, or a little over 3 decades on this earth, that percentage has doubled. But what's more alarming is also during those decades, the percentage and the rate of obesity in our children has tripled. So overall, approximately 17 million children are now considered obese. And many of these children already have 1 or 2, quote unquote, adult chronic diseases such as diabetes, high blood pressure. I've seen children that have carotid arteries that are so thickened you'd typically see that in a 60-year-old. So I urge you, the time to take action is now. We must take action against this epidemic, not next year, not 10 years from now. If we don't change the trajectory of this current path, this will be the first generation of our children that will not, on an average, live longer than their parents did. Let me say that again. This could be the first generation that does not outlive their parents. And centuries of progress made in public health will be eroded. Healthcare costs of chronic disease will proceed to overwhelm our healthcare system. I've had the honor and the privilege over the past year to travel the nation with Acting Surgeon General Stephen Galson. Admiral Galson, he has an initiative called Healthy Youth for a Healthy Future. And Surgeon General, he's visited over 40 states in our great nation, honoring groups that are leading the fight against childhood obesity and fostering discussion on collaborative ways that we can make an impact on this epidemic. It's been an honor to work with such a Surgeon General who doesn't just talk the talk, but walks the walk. And my focus on these trips is highlighting the physical activity guidelines for Americans that was put forth last year by Health and Human Services and the President's Council on Physical Fitness. That was led by Melissa Johnson, who I believe is in the audience today, and I commend her for that. These are the first ever comprehensive physical activity guidelines for Americans that are backed by years of scientific research. I want to talk a bit about how much good health and physical activity has played in my life. The core values that have guided me my entire life. Taking care of my body has served me well, not only physically, but also mentally and spiritually. For me, playing competitive sports and being disciplined about nutrition, physical activity has fostered confidence, perseverance, and team spirit that has led me to this room today and has given me the opportunity to work on improving the health and well-being of millions of children who are our future. That's why I think that it is so important to promote physical education, find ways to incorporate physical activity into classrooms and make it a part of our learning. What stands out so clearly in my mind is the President's challenge that we took when physical education was a daily occurrence within our schools when I was in elementary, middle, and high school. As I close, people ask what the key is to what's the key thing to blame for the rise in our childhood obesity numbers? They want to point fingers, point to one thing, what's the root cause? But the key is, in reality, that the problem is multifactorial. We each have a role that we can play. As parents, leaders, public figures, being good role models for our children. Schools teaching healthy habits, and creating opportunities for activity, much of what Governor Huckabee talked about. Or businesses can devise programs in the workplace to get employees active, as Mr. Burd will speak to. But the government can emphasize prevention as well and support healthy environments. What you do here in developing and implementing health policy has been essential over the history of our country to improving public health, preventing disease, and saving lives. Government needs to look at incentives that encourage healthy behavior. We should look for creative solutions to address the barriers encountered by our communities out there that don't have access to fresh fruit and vegetables. We can't expect people to eat healthy if they don't have access to those foods. In the same token, we need to allow for safe places for outdoor activity. We can't expect our children to be active if they're in dangerous communities. And once again, we should encourage funding for the medical education and preventive medicine and primary care. I've been touched by the efforts of the communities to promote the health of their people. So impressed by our country coming together and the groups out there dealing with this issue. But I've been equally, if not more, touched by the smiles and the laughter of the kids we meet throughout the country. We all have a responsibility and an opportunity to make a difference. I bring you these words today on their behalf, and more importantly, on behalf of all the children nationwide. I have made a personal commitment to these children to help them realize their full potential. So I ask you today, please join me, step up, encourage others to take a role and yourselves play a role. Thank you for this time, and thank you for your commitment to prevention in the Republican Policy Committee.
Thank you, Dr. Baldwin, and thanks for your advocacy, for very effective advocacy working with the Surgeon General. Steve Burd has already been introduced by Senator Ensign. I want to recognize that Senator Richard Burr has arrived. Senator Burr is one of the leaders in Republican and in the Senate in health policy. He introduced yesterday a major bill on health care reform, and we'll be going to him for comments and the first questions after Steve Burd. Steve, welcome. You've been talking both with Democratic and Republican senators for quite a while. We've all been very impressed. We appreciate the time you've taken to come all the way across the country to be here again. And we're getting to the point where I think all of us will be specifically interested in the provisions you think that ought to be in any legislation that will help eliminate the obstacles to permitting employers such as yourself to give incentives for wellness and prevention. So we look forward to your testimony. Thank you.
Okay, thank you very much, Senator. I too appreciate the opportunity to address the Policy Committee. I'm going to try to take the Safeway story, which I've told often, which I prefer to do in 45 minutes, and I'm going to collapse it to 5. Just as a basic set of numbers, everyone needs to understand that we're a pretty large organization with some 200,000 employees. Of those 200,000 employees, we have about 30,000 employees that would be non-union employees, and the balance would be union. The reason I make that separation is that what I'm going to talk about in terms of the progress that we've made in health care, it affects both populations. We've made more progress on the non-union side only because we don't have to wait for the next bargaining event to make that happen. I'm absolutely confident, given my conversations with the unions that represent Safeway's employees, that we'll make the same progress in those environments as well. It all started in 2005. In 2005, we had health care costs of roughly $1 billion, and they were increasing at a rate of 10% a year. So in 3 years' time, I would see a $300 million increase. We as an organization pride ourselves in our ability to look at issues and problems and see if we can solve them. And this to us was initially just a cost problem. We made a great discovery, which I think was little known at the time, may still be little known today. And that is that 70% of all healthcare costs are driven by people's personal behaviors. As a business guy, that was a large dose of good news, because it said if I could influence behaviors of 200,000 people, I could have a dramatic effect on their health and therefore our costs. The second major discovery, which the governor talked about earlier, the numbers are between 74 and 80%, but well recognized in that range, you have 4 chronic diseases which are consuming all these costs. And it's fascinating when you look at the chronic diseases, the #1 disease in terms of cost is cardiovascular disease, and yet 80% of cardiovascular disease is preventable. In other words, if we change our behaviors, we can prevent that from occurring. You've got cancer. The numbers range from 40 to 60% of all cancers are preventable through behavior change. Then you've got diabetes. With most diabetics being type 2, at least 80% of type 2 diabetics are preventable and, in fact, reversible. And then fourth, you got the conditions of overweight and obesity, which really affect all of these. We've taken a very holistic approach to healthcare at Safeway. And in essence, we're building a culture of health and fitness. And I think the things that I want to talk about, which fit into that category of prevention and wellness, that are unique to us, will be of keen interest to the committee here. We've made dozens of changes over the last 4 years. Those changes have allowed us to keep our health care costs on a per capita basis absolutely flat, at a time when the rest of business in American industry is up 38%. We've done it by encouraging our employees to be healthier. Last year, we introduced a program that's called Healthy Measures. And under the current law, it's important that that be a voluntary program. 74% of our employees signed up for Healthy Measures. And right now, the 4 measures that we're focused on would be smoking. Second would be obesity. Third would be controlled cholesterol and controlled hypertension. So what we've done is we've structured incentives so that if you don't smoke, you have a lower premium in our company. If you are not obese, you have a lower premium. If you're, it's okay to have hypertension, but it must be controlled. In fact, 17% of the people that were measured discovered for the very first time that they had hypertension. And then cholesterol level, also people discovered that they had high cholesterol, so they could begin to do something about it. We provide, if you have family coverage, the total incentive granted to our employees is just under $1,600. The reason it's not more is the current HIPAA legislation, in conjunction with ADA, actually limits the incentives that you can provide. When you consider that a smoker costs about $1,400 a year annually to insure, that extra cost, our incentive is around $312. We'd much prefer it be closer to the cost of the behavior. Obesity, our incentive is about $312 for an individual. And again, obesity costs are estimated to be something north of $800. And so that's clearly an area where I think Congress can make some change. And you also need to make some change in ADA, because ADA works with HIPAA, and it further constrains what you can do in the workplace for incentives. I'm a firm believer that if you make changes on incentives, if you make changes on cost and quality transparency, provide electronic medical records, get some of the inefficiencies out of the system, that consistent with what Senator Ensign said in his opening remarks, you can finance health care for the 47 million uninsured out of the efficiencies in the system. And I consider behavior to be the fuel that really drives the engine of change here. The other thing that's unique about our program, if you have a BMI index of 36, which is considered obese, and you make 10% progress in the next 12 months, we write you a check to reimburse you for the premium difference you had at the start of the year. We do the same thing for smoking, cholesterol levels, and hypertension. It's my belief that 35 to 50% of our employees will line up at the refund window at the end of the year. And so we just firmly believe that it's important for the nation to, prevention and wellness is great, but to me that's high-level discussion. But we need to get it down to the level of behavior. Behavior really makes a difference. And as much as I would like to argue that we've been innovative, we've done nothing more than borrow from the business model of the automobile insurance industry, where driving behavior actually matters, and there's a difference in premium. We think that should hold true for healthcare. And, there's no way to get healthcare costs down, I think we've all said it, without making Americans more healthy. And incentives do a good job of accomplishing that.
Senator Burd.
Thank you, Mr. Chairman. Let me also welcome all 3 of you. Governor, great to see you again. And I think you've got a trip to North Carolina pretty soon, if I remember. I'm sure all of you have alluded to this, and Steve, you alluded to it even in more specificity, and that's that prevention, wellness, and disease management are absolutely crucial. As we sit here today, knowing that there's going to be some health care proposal over the next several months, certainly before the end of the calendar year, it's my belief that everybody that comes out with a health care proposal is going to say, well, we do prevention, wellness, and disease management. Yet, having worked on a bill, I understand that it's extremely difficult to figure out how to create the right incentive for prevention, wellness, and disease management to actually be carried out in a private or a public system. Ms. Burd, you were very creative at Safeway, as was Dell, as was SAS, where if employees didn't enroll, you went the route of writing them a check or giving them a financial incentive to do it because the dollars and cents you could prove. And I guess the first question is to any of you, without truly addressing a model that promotes, creates the incentive for an investment in prevention, wellness, and disease management, can we expect that we have had true reform? And two, is it possible in your estimation that you can construct healthcare reform that insurers, private insurers, see the benefits of investing in primary care, investing in the education for disease management, so that the back end is that we severely affect downward pressure on the cost of healthcare in the future? I'll start at either end.
Let me address a couple of areas. One is, I think it's very important that any of the decisions made be made on the basis of good research and good data. One of the things that we did, we employed a company, Health Media, out of Ann Arbor, Michigan, to evaluate the things that we were doing for employee incentives. We found that when employees participated in the incentive programs, I didn't mention all of them because of the lack of time, but when they did that, particularly in the smoking cessation and the weight control, in the activity increase, they gave us back, by research, by the data that we have, $3,300 a year in increased productivity per employee. That's cash money back to the employer. That's significant. And I know that when Mr. Burd was talking about some of the specifics, these are the kind of pieces of data I think that become very important in presenting why this approach of prevention is critical. Another area that we saw real results on was in childhood obesity. Robert Wood Johnson Foundation came to our state, evaluated and recognized that we had become the first and at that time the only state that had seen a reversal in the trend of childhood obesity from skyrocketing trajectories upward to actually stopping and seeing a slight decline. We took aggressive approaches in everything from school lunch menus to the presence of vending machines, physical education, and not just classes. That's a big mistake, thinking that if you have PE classes, you've fixed it, because if it's nothing more than the continuation of competitive sports where a few kids play and most kids watch, you haven't done anything but exacerbate the problem. But true fitness approaches that tailor to the individual student, when those approaches are made, there can be quantifiable results. I want to address also the issue of why don't more of the insurance companies cover the wellness and prevention models. I sat down with a group of insurance CEOs because I wanted to know, how come it is that you'll pay $35,000 for the amputation of a foot, but you won't pay for a visit to the podiatrist to save the foot before it ever gets that bad? Why do you pay $100,000 for a quadruple bypass, but you won't cover the cost of going to a nutritionist or a trainer so the person could maybe prevent the quadruple bypass? The harsh reality is that we don't have a system that makes it very practical. Insurance companies, like any business, have to make a profit. They base it on the actuarial tables. And because the current system in America is an employer-based insurance provider rather than the personal and portable approach to insurance, the insurance companies know by their research that the average American will change jobs every 7 years, if not less. And in the change of the jobs, they'll also change insurance carriers. Insurance companies simply cannot afford to provide the front-end coverage of prevention when the real savings will be in the outlier years, when the likelihood is the insurance company providing those provisions early in a person's career are only making the coverage less expensive for their competitor. Now, if there was a system in which the person owned their insurance and was likely to keep it for an extended period of time, like we do our home insurance and our car insurance, because it's personal to us and it's portable to us. When we move, we keep our insurance carrier in most cases. Then the incentives dramatically change. then the insurance company has a vested interest, because if they think they're going to be the insurance company for me in 20 or 30 years, or even in 15, they're much more interested in how I'm going to be costing in those years. And there is a dramatic difference in the cost between the prevention-focused patient and the intervention-focused patient.
Mr. Burd?
You know, I'd like to provide maybe a sort of a different angle on that. First of all, I think our proof rests with our numbers. The rest of industry is up 38%. Our cost on a per capita basis are flat. And that's not a cost shift from the employer to the employee. That's the all-in cost. That's their portion plus the employer's portion. I think what has made our program easier to implement, Governor, is that we're self-insured. And because we're self-insured, we're free to design our own plan. And we actually saw a 13% reduction in costs in the very first year. We've added a series of benefits that we think create better long-run cost control, and that's why we're only flat. Otherwise, our costs would be down. If we had cost and quality transparency, and I have some ideas on how we could capture that, I would tell you that we would take our costs down for another 5 or 6 years. If you look at our numbers and some of the detail, our obesity rate in our company is 70% of that of the nation. That suggests we're doing something right in the area of obesity. Our smoking rate is 70% of that of the rest of the nation. I would tell you that incentives work. You look no further than the recent tobacco tax increases. I've followed them closely. We provide 100% cessation-free products to people that are smokers, and a lot of states do that. The state of Michigan does that. And when the tobacco tax went up, the equivalent of $1 per day for the cost of a pack-a-day smoker, the call center had an increase of 1,900% in its calls. California, which has the second lowest smoking rate in the nation, had a 300% increase in its calls. Now that is a fractional cost of the real cost of insuring a smoker. And so I really believe that these incentives make very good sense. And as long as you are really focusing on the healthier employees, you'll get that productivity pop. You might not see it, maybe not everybody will see it in the first or second year they do this. They will see it in productivity, and they'll see it immediately. We have a feature in our health care plan, which, as far as I know, no one else does. It costs money. It's a feature called, I call it a cancer concierge service. If any one of Safeway's 200,000 employees are diagnosed with cancer, they call a hotline. We walk them through, in a hand-holding fashion, the diagnosis and treatment process. And if they would like, we connect them to a major cancer center in the United States. That buys good health. It buys great loyalty. So we don't have sort of the turnover statistics that maybe some other companies. So we're investing in our people. We think it works. The last thing, not to occupy too much of the time, but one reason why the insurance companies don't offer plans like you described is all too often the relationship is with a human resources person, the benefits person in the HR department. They're not that eager to disrupt the work environment. We have a non-smoking campus, all of our stores, all of our distribution centers. That creates calls to the benefits person. And we have this smoking incentive, so there's a differential premium for smokers. But as CEOs get conversant in this subject matter, I think they'll all be in favor of incentives.
Mr. Burd, if I could ask you, quite an undertaking by Safeway. I'm sure a lot of it was because it was the right thing to do. Could I ask you what percentage of it was because the healthcare model that you had was not sustainable and you were trying to put in place something that was sustainable financially into the future?
I mean, clearly that was the initial motivation, this $100 million annual increase in cost. And so once we discovered that we had figured out a way to control healthcare costs, we thought we should share that with everybody else. I have told this story to more than 500 CEOs in this country. I've walked the halls of Congress, talked to more than 60% of the U.S. Senate, had conversations with the White House. I just believe so strongly in the benefits of doing this. And there was a time 4 or 5 years ago that I genuinely was concerned that somebody might think nationalizing health care was a good idea. And it's really a bad idea because it will remove forever the economic incentives to actually encourage the population to be healthier.
If I go to Dr. Baldwin for just a second, tremendous perspective on obesity in children. Is it a diet problem or a lifestyle problem or a combination of both?
Absolutely a combination, Senator. There's so many factors that go into it. And what I struggle with when I go out and speak with these children is what is going to motivate them to be active, to be healthy, to eat right. And continuing on the last question and a conversation we had about incentives, on Monday I was at a school in Washington right here, and I said, what's it going to take to get you to work out 60 minutes a day? And this little child said, pay me. And really, that's the reality of the situation right now. And the way that you affect behavioral change is, one, you could start with having somebody that is right there by your side, it's motivating you to get over that hump to physical activity. Two, you see a role model, a public figure, such as Governor Huckabee, such as a professional athlete, someone that you look up to. Hopefully, you'd like it to be your parents that you want to be like, and they enable you and empower you to have behavioral change. And this just isn't with children, but this is across the country in all populations. But what's really going to get people at the end of the day to start changing their behavior is, hey, if you have a choice to go and get a bottle of water or a bottle of soda, and if you get a bottle of water and we're going to give you 50 cents back in your pocket, or if you meet these benchmarks at your workplace, we're going to give you a rebate. That's what it is. And I believe strongly in that incentive process. I also believe strongly in the importance that role models play for our children, and that each and every one of us out there has a role to play in affecting the behavior of our kids. Kids just want to have fun.
I've taken more than my share of time. Let me once again thank all three of you and share with you, Mr. Burd, I'm not yet convinced that we shouldn't be scared of government-run health care. I think that that's still on the table, and I think the only way to make sure that that doesn't happen is to learn from what you've done as a self-insured company and others around the country, to look at the incubators of breakthroughs like Governor Huckabee talked about, to listen to folks like Dr. Baldwin who quite frankly put in our face the realities. If you want to solve obesity, you got to think it different than we've been doing it. And I think that's what you've applied at Safeway. It's what other companies have. It's what the states have done. My hope is, and my belief is, that we've got to come up with a product at the end of the day that's superior, or the punt to will be just put more money in it, cover more people, but don't reform the system. And I've heard it from all three of you. If you don't reform the system, then we will just have a bigger mess 2 years from now than we have today. I thank you.
Thank you, Senator Burr. We've been joined by two other members of the Republican leadership in the Senate, Senator John Cornyn of Texas and Senator John Thune of South Dakota. And I talked with Senator Ensign. What we'll do is go to Senator Thune for questions and comment, and then to Cornyn, then Senator Ensign will resume chairing the hearing. Senator Thune.
Thank you, Mr. Chairman, and I want to thank our panelists. Governor, nice to have you here. Mr. Burd, Dr. Baldwin, for sharing your insights. And maybe Lamar already mentioned this, but we've had this discussion amongst ourselves that this generation of Americans will be the first generation of Americans that doesn't outlive their parents. That is a stunning statistic when you think about the fact that we're spending 17% today of our GDP on health care. And what are we doing to affect the overall outcome and the longevity of our citizens in this country? To me, we're spending money in the wrong places, which begs the question about how do we fix this problem. And I know that in my state of South Dakota, we have acute problems, particularly on our reservations with diabetes and obesity, and it seems to me at least that many of those issues are impacted, as has already been mentioned, by behavioral change, lifestyle changes. And I guess I'm interested in just sort of hearing, and this is more from a 30,000-foot perspective perhaps. Governor, you've done as governor, some very innovative things in your state in that regard, with regard to healthcare policy. Mr. Burd, you obviously have innovated in a corporate setting and had a lot of success in impacting outcomes, driving down costs and whatnot. Just to get your thoughts about how do the experiences that you've had in sort of the laboratories of change, which are the state governments, and in the corporate sector, translate into federal policy changes that we're looking at making here. We all agree that we've got to have some sort of financial incentive to change behavior, but prevention and wellness is such an important component of any debate about healthcare reform, and yet we struggle with how do we implement those types of changes. And Dr. Baldwin, I certainly would welcome your perspective on that too. But as we go about this debate of healthcare reform, we're looking at the possibility. You know, there's a philosophical debate here about whether or not we're going to have a national sort of single-payer system in this country. Some believe in that. I don't happen to. I think that we ought to encourage and figure out ways to make our free market system work better, and many of you have had success doing that. How do you translate that into some big federal policy change or reform, some of the things that you've had success with at your level?
A couple of observations. One is I would highly engage the governors across the country for the reason that virtually every governor in America is probably his or her state's largest employer. In most states, the state government is the largest single employer within that state. I don't know of many exceptions. I know that in my own state, it would take all of the employees of Walmart and Tyson Foods, two fairly large and recognizable companies combined, and they still wouldn't equal the number of state employees in total. The second thing is that most Medicaid programs within the state represent the largest insurance pool that exists in that state. So governors are going to be approaching this as acutely as anybody in the country because they're CEOs of both the largest employee pool within their state, the largest insurance pool within their state, and every single governor is faced with a huge fiscal crisis in large measure driven by the runaway cost of health care in those two programs. So they're going to look for innovations, but they're often stymied by either roadblocks in the law or just roadblocks in the culture. But those are the laboratories where, along with companies like Safeway, and I want to tell you, I don't know of anyone in the country who's done anything more innovative than what Steve Burd has done at Safeway. And he's done exactly the kind of model that needs to be held up at the national level to prove that incentives work, that there is a way in which these costs can be contained, but more importantly, it's not just about holding down costs. We can hold down costs by cutting benefits and raising deductibles, but the long-term cost is more expensive than less expensive because it means unhealthier people, greater levels of chronic disease. The model that he's approaching actually results in lifestyle changes that results in quality of life for the people and longer life and less expensive life. So the states are a great laboratory for this to happen. But one thing that I'm hoping will happen in this debate in Washington regarding health care, this is not an issue that can be resolved in an election cycle. It's a generational issue. It's going to require a long-term commitment to fundamentally changing the system itself, which is at this point not really a system. And a couple of examples. The average physician in training gets 11 hours in his entire medical school training on the issue of diabetes, yet he will see more diabetes cases than probably any other one condition. So how we train doctors, how we deal with the issues at the insurance level. We reimburse for procedures, not for quality. Doctors get nothing in the way of incentive if their patients actually lower their blood pressure, lose weight, take more steps. They get reimbursed for procedures. What if we had a system that not only reimbursed for the processes and procedures, but actually reimbursed both the patient and the physician with incentives for the quality of health care delivered? And that's a real important factor that's not often brought into the mix. And the final thing I want to mention in this terms of generational change, we've seen it already. In my lifetime, I like to point to 4 major transformations of culture. And this is really what we're talking about, a cultural change. But if you think about it, litter, seatbelt use, smoking, drunk driving, roll the clock back to the late 50s, early 60s on all 4 of those issues. If this meeting had been held even 30 years ago, there would have been ashtrays and half this room of adults would have been smoking during a hearing. If someone lit up a cigarette in here today, we would all attack them because the culture has dramatically changed. When I was a kid, nobody had a seatbelt in his car. That was unheard of. It wasn't even, it was an aftermarket device. You had to go and have it put in. And if you'd gone to a mechanic in my state and said, I'd like to put in a seatbelt, he would have looked at you and said, you want to do what? You want to strap yourself in a car? They would have thought you were crazy to have done that. Now, every state but New Hampshire now has a seatbelt law requiring it. And of course, their motto is live free or die. So there's a different reason for New Hampshire. But my point being is that in all of these areas, and that includes litter and drunk driving, we've seen dramatic changes in the way we approach these issues because there were cultural changes. I suggest there were 3 stages. First, attitudes change. Secondly, the atmosphere around these issues changed. Thirdly, there was action. We codified into law what had become a new behavioral norm. That's government's involvement. Government has a role to help influence through the attitudes, to help influence through the adjustments of the atmosphere in terms of taking the ashtrays away and putting no smoking signs up. But ultimately, the role of the government is not, it can't tell people what to do or not to do. But once the culture has shifted and people have adopted a different cultural mindset, then the government does need to move to capture and to codify the new behavioral norm. But if they try to create the behavioral norm by mandate, it will have disastrous consequences. And one of the concerns I have when I hear about national health reform is that the government is going to go in and nanny state us into behavioral changes without the incentives, without the kind of cultural transformations that are necessary.
We want to hear from Dr. Baldwin and Mr. Burd on that, but I want to make sure Senator Cornyn has a chance to make a comment or ask a question while he's here. So, Senator, you want to go next?
Well, thank you, and we're delighted to have you here, Governor and Doctor and Mr. Burd. Thank you for being here. And I apologize if what I'm going to ask has already been covered, but it really is something that I think is at the core of the problems we have today with regard to health care and empowering consumers and patients as opposed to the government to make health care decisions on our behalf. Mr. Burd, I know that at Safeway, you have, obviously you're a big company with an ability to collect a lot of important information about cost and outcomes of healthcare procedures. And I recall you talking about just the variations in costs of common procedures like colonoscopies. I'm just wondering if you would tell us, I know you've said this before, but I'd like for you to repeat it. What can we do to empower patients and consumers with information about costs and outcomes that will make them smarter consumers so they can make decisions about their health care instead of the government rationing care?
Sure, I'd be happy to. I think the main role of government here would be to remove the obstacles so that a free market is capable of working. Markets can't work unless consumers have information about cost and quality, and then unless those consumers have consequences. I go back to your example of the seatbelt. Those automobile insurance companies, should you be ticketed for not wearing a seatbelt, your premium will go up because your behavior is inconsistent with low-cost automobile insurance. Under the 1996 HIPAA legislation, there is a little-known provision in that legislation which allowed companies to differentiate premiums for their employees to the tune of 20% of the cost of that care. And so we looked at that provision and decided to act upon it. And so that limit, though, is too limiting. earlier I mentioned that let's take an employee who has family coverage and there are two people in the family that smoked and are both obese. The cost of the two smokers is $2,800. The cost of being obese is another $1,600. And, you know, we only have about $1,500 to $1,600 worth of flexibility. You will clearly drive a change in behavior if you increase those limits. And the way the market will work, Safeway and other quick early adapters will take advantage of that, and we'll have lower health care costs and, frankly, healthier employees who are more motivated and loyal, and we'll win in the marketplace. And eventually the marketplace will have to adapt the same thing. There's also a companion legislation, which is ADA, which has to be read in conjunction with the HIPAA provisions, which also are somewhat limiting. So my advice on this issue is, in fact, to raise those limits and adjust the language in ADA. The other thing that you talked to, Senator, was transparency on cost. There's a tenfold difference in the cost of a colonoscopy within 30 minutes of our office. There's a fivefold difference in the cost of a standard blood test within 10 minutes of our office. And people don't normally know about those differences. We are cobbling together a transparency model for our employees so that they'll put their zip code in on the health site. They'll look at the different places where they can get a colonoscopy procedure, and then we will limit what we will pay. And so they're welcome to have the $7,000 colonoscopy, but we'll pay $1,200. And we pay for 100% of that kind of prevention, but only at a reasonable cost.
I confess to being a little apprehensive about bargain basement colonoscopies, but we won't go there.
Yeah. Well, I think you probably know. We won't go there, but the difference, cost and quality are not necessarily correlated. I think Dr. Baldwin could confirm that. Cost and quality are not always correlated, and that's why you need quality information about these procedures as well.
Right. Thank you very much. I want to just ask one more question. Governor Huckabee, let me just ask, based on your experience at the state level and your observations of what's happening here nationally with regard to how much money we spend on health care, which maybe I should call it sick care, since we don't spend a lot on health care. We spend a lot once you get sick, but not keeping people healthy. But there's some folks in here in Washington who seem to think that 17% of our gross domestic product is not enough money. We need to spend more, and they say if we spend more, then we'll actually save more later on. Besides being kind of counterintuitive, have you ever seen the federal government increase spending in any sector of the government, and then on the promise that someday, somehow, some way, later on we're going to save money? And what is your prospect of that happening in the healthcare area?
Well, the level that we spend out of our GDP is already unacceptable, and it's about, for example, if we were spending 11% instead of the 17%, it'd be about a $700–800 billion a year savings. There's more than enough money within the system, and I believe that either Dr. Baldwin or Steve Burd may have alluded to this. Our problem is not that we don't have enough money in the overall expenditure. It's that we're spending it in the wrong places. And when most of it is being driven to the express expenditure of a handful of people who are really, really desperately ill with chronic diseases, then there's not enough to cover the sort of the basic health care needs. We could cover every child, every young adult. It's not that we don't have amount of money necessary, but it's that we're misspending it because we have not changed our approach from a true sick care system to a health care system. And one of the challenges that I urge you to consider is that any changes at the federal level will have a dramatic impact upon the states. For example, if new requirements are that Medicaid covers certain things, you're going to have a dramatic impact on state budgets that are already hemorrhaging and in many cases sucking air. This is another sort of maybe unforeseen consequence of a national approach. The private sector approach, even state-by-state approach, where the ideas are tested, proven, and then implemented make a lot more sense than taking a theoretical idea at the national level, hoping it works, but most likely it won't. And a great example is, I've said many times, the number one economic issue in America is the health care issue. It's not just a health issue, it's the economic issue. Toyota has $110 of health care in each car they build. GM has $1,500 of health care in each car they build because of the legacy cost related to older employees who have chronic disease. We wonder why the car industry is in trouble. A lot of it is, it's not about the cars, it's about the cost of the health care of the people who built the cars 30 years ago. And until we start addressing those issues, we're going to see increased economic challenges that we're not addressing. And my great concern when I hear the national debate about let's get the national government, the federal government involved, single payer would be the single greatest disaster if for no other reason. It takes every incentive away for doctors, pharmaceutical companies, and university researchers and everyone else to start being innovative and coming up with the new modalities that can actually save lives and save money.
Many of us would like to see, for instance, the small business health plans be able to join together and to be able to develop legislation when they join together to be able to put in the incentives as well. So these are all things that we're working on and we're thinking through. And I guess I want to, Governor, start with you on the Medicaid aspect. What incentives would you suggest that we put in? Because you all have talked about basically these 4 conditions, focusing on these 4 conditions where most of the cost, if you focus on 500, it's too many. But if you just focus on a few, and how would you structure maybe putting the incentives for instance, for Medicaid? And then Dr. Baldwin, I'd like you to maybe comment also on at the national level, maybe FEHBP or some of the other things.
The greater level of flexibility is the single most important tool that governors have. Every state has slightly different populations, different risks, but there are certain things that are common. The greater level of flexibility, and that was a fight that I know I had when I was chairman of the National Governors. We came to both the House and Senate, got some reforms that all the governors, every one of them agreed to, and that was helpful. But what we need are ways in which to implement different approaches. For example, in diabetes, rather than saying everybody needs to go to endocrinologists, which is not realistic, and the endocrinologist cannot spend 30, 40 minutes with a patient, we created 27 diabetes education centers with carefully trained diabetes educators. If you can't prevent the disease and then you're unable to reverse it, then for heaven's sakes at least manage it. And the best way to do that is to have people who are trained to work with the diabetic so that they can manage their disease. Same thing true with blood pressure. It doesn't always require a physician, but we do have to have an ability to reimburse the people who are providing it, and it may be at a much reduced cost than if you drive that person to the physician himself. That's one way. Reimbursing for the programs like the smoking cessation, the weight loss, those are very valuable tools in the toolbox to get people to change their behaviors. And then the incentive rewards. We found that when we started,
do we at the federal level, do we just allow states to do that, or do we actually put in other words, should we say to the states, we'll match X reimbursement if you'll do this?
In some cases, the mandates within the Medicaid program require that it be provided by a certain vendor, and a lot of that is due to the politics of those vendors having a wonderful presence to say, we have to provide it. Then they complain about that the level of reimbursement isn't adequate, which it isn't, but that's part of it. But when the state is paying a significant portion of the Medicaid, that partnership still means a huge cost to the state. So what most states tend to do is just not provide it at all, because not providing it is less expensive than providing anywhere from 25 to 60% of it.
Okay, Dr. Baldwin.
Yes, Senator. Some great points made recently by Governor and Mr. Burd that I'd like to comment on, and which worries me a great deal. We talk about the money being spent on health care. It's not being spent wisely. And let's say that we do have a shift from sick care to rewarding prevention and healthy behaviors. We need the physicians, we need the public health educators to deal with them and to take that on. And currently, preventive medicine residency programs are not being recognized. They're paying $10,000, $20,000 a year. Primary care physicians. I know that my colleagues and up-and-coming medical students are not going to go into the primary care field if they're not going to be reimbursed for the care that they're providing, and if they're not going to make the type of money that their fellow peers are making in specialties. So we need to make sure that the money that we are putting towards healthcare is being allocated to those treatments and those things that we need to do in education upstream. And if those people aren't in existence, it's not going to happen. And so I really urge you, to look into providing funding. If someone wants to go and be a primary care provider, pay their way through medical school. Think outside the box on ways that we can make that happen.
Right. We have, as you know, Medicare pays a large portion right now of graduate medical education. And we had this discussion yesterday in the Finance Committee about indirect graduate medical education, that 50% of it is taken up by 5 states. In large hospital settings, that isn't the way that most people practice today. And you just mentioned the preventative, residencies out there are really the way that most doctors are. We're not training our doctors the way they're practicing today is the bottom line. And that was a point that I made very strongly yesterday in the Finance Committee. We need to change, and that's the largest portion. The indirect is the largest portion of the graduate medical education dollars from Medicare, and I obviously hope you can work with the White House and try to help us change this, because the politics are such that those 5 states don't want to give up that money, and and by the way, they aren't the biggest population states. They aren't California, they aren't Texas, and they aren't Florida, and so it's pretty remarkable that 5 states without. A couple of them are, decent-sized populations, but they aren't the biggest population states, and they still get 50% between those 5 states of that money. Mr. Burd, if I know we've talked, and you've talked about what Safeway did on reporting. One of the proposals that has been kicked around is this idea of, if you can get doctors to practice best practices, if you can maybe give them a safe harbor if they'll do 2 things. Practice best practices, but also self-report. You've talked about needing more information out there, because Safeway had to create your own information for your employees on how much a colonoscopy is in your area, on how much various procedures based on cost and quality, where the federal government has a lot of that information already, but we could even have a lot more of it. For instance, if doctors were reporting and they knew that they could self-report without that then being used in a lawsuit against them. That is something that I think that we need to look into, and when we're doing this healthcare reform legislation. But Ms. Burd, could you elaborate more on what you had to do to put all of this information together, and also if you could maybe give the example that I heard you give on Lipitor, once again providing information to your employees.
Sure. I'll do the Lipitor example first. There are, 11 or 12, maybe even more different cholesterol-lowering drugs that people can take. And as a branded drug, that was the most expensive. So one of the things we did was we just completely flipped our copay tables in our healthcare plan, so that we knew what we would pay for a generic drug. And we altered the copay on the branded alternatives so that the copay on that particular drug today is $70 versus $5 for a generic. We sent a letter to all of our employees and said, please consult with your doctor. We believe that in 85% of the cases, a generic will work. And if we got a letter from their doctor that said they tried the generic and only this drug worked, then we would give them the same copay as we would for a generic. And so we did that across 13 different categories of drugs, and it had a major effect. We got dramatic switches to the generic drug, and always in consultation with the doctors. To your last question about Medicare, to me it's pretty clear that Medicare has to follow the kind of model that I'm advocating for the private sector, because we don't want behavior to matter only when you're employed, and then when you retire it no longer matters. And I'm no expert on Medicare, but one of the more difficult things with older patients is they don't always take their medications on time. And we operate over 1,300 pharmacies, and I can tell you that that the compliance with the regimen is only about 65%. And so if you choose to, for 3 days, not take your hypertension medication, that will expose you during those 3 days to an event. You can incentivize diabetics. I think you know my wife is a 48-year diabetic. For every 1,000 diabetics, there are 217 visits per year to emergency. In 48 years, my wife hasn't had an emergency visit, and because she's well controlled. We'll probably make some changes to our health care plan next year that will provide some incentives, which in all likelihood is going to be free product instead of any copay to diabetics that are controlled. And you can do that with Medicare as well. I think the opportunity to innovate here is absolutely infinite. I mean, it's infinite on the insurance employer side. It's infinite on the provider side. You're probably familiar with what Intermountain has done in Salt Lake City. They discovered that the real cost in a lot of their surgical procedures were post-operative infection. So they were meeting the standard provided by, I guess, AMA or others, and they decided to reduce their rate of infection tenfold by giving antibiotics in advance of the surgery. They then lowered the cost of their surgical procedures and took business from crosstown rivals. That's the way the market works. And on the issue of prevention and wellness, I like to think of behavior as a form of currency. And the healthier your behavior, the more currency you have, and that currency is used to buy down your medical costs. But there's predominantly, I think, if markets work in all free markets, costs go down and quality goes up. We can have that experience in healthcare.
Well, I want to thank, I know we told you all it'd be an hour today, and we've already gone over that as normal in the U.S. Senate. But I want to thank all of you for what you're doing out there and to encourage you to continue. This is really, I think, the key to healthcare, actually making it a system that will work for all Americans at less cost and obviously have people live in better quality lives. So I appreciate all three of you. You were a perfect panel for us today to be able to have from three different perspectives, and I appreciate what you're doing on a personal level. You're all showing. I know, Steve, you didn't mention your own family's heart history and quite significant. We do have to get some of these advocacy groups to change their mental thought processes as well. I mean, I've heard that the American Cancer Society, for instance, is against us providing incentives for decreasing tobacco use other than tobacco taxes. They don't want to see a change as far as premiums are concerned, which doesn't seem to make any sense. It would seem anything that we can do to decrease tobacco use in this country would be a very good thing for all Americans. And so I think that that's something that we need to continue to work with all of the various advocacy groups, and even with obesity. I know there are some people who genetically there's not a tremendous amount they can do, but the vast majority of the people who are obese, it is strictly behavioral. It is it's not something that they can it is something that they can overcome. I mean, Governor Huckabee, you're a great example of somebody who turned his life around, who's, and you don't have to become a marathon runner like you did to do it. You can do it with real common sense things. And I think if we provide the proper financial rewards for folks and use a carrot and a stick type of an approach, whether it's Medicare, federal, private insurance, Medicaid, all of the various programs that we have out there, I think that we can turn this thing around and truly end up with a healthier society. So I thank all of you for being here today. You're an excellent, excellent panel, and thank all the senators as well.